Okay, welcome everyone, and thank you so much for joining today's webinar. Today, we are launching our Implementation Science Special Interest Group with co-leads Drs. Devon and Cara McDermott. We also have on our panel today Drs. Lisa Zubkoff, Dan Matlock, and our own Christine Ritchie representing the Executive Committee. Just a couple of housekeeping items. All attendees are muted and video cannot be turned on. We also ask that you please use the Q&A feature, which is a button at the bottom of your screen to type in any questions. And if you have more questions that are technical in nature, please feel free to reach out to me with the chat. Please share your questions and comments at any time, and we'll break out in discussion in the last 20 minutes of today's webinar. So I think I'll get started by asking Dr. Ritchie to please formally introduce our speakers.
Well, greetings, everybody. It's always fun to be able to talk about our latest lineup of speakers for a new special interest group. And we are just more than delighted to have with us today an incredible panel of researchers doing implementation science. Dr. Devon is a health services and implementation researcher and assistant professor in the Department of Population Health Sciences and a member of the Duke Cancer Institute. Dr. Chek is also a member of the leadership team for the Implementation Science Research Collaborative at Duke, and her primary research interests are quality of care and implementation of evidence-based practices in oncology. She's particularly interested in symptom management and other aspects of palliative care and cancer. Dr. Cara McDermott is a PhD PharmD and a K-12 scholar at University of Washington in their Implementation Sciences training program. She's acting instructor also in the Cambria Palliative Care Center of Excellence in the University of Washington School of Medicine. Next, we have Dr. Lisa Zubkoff. Dr. Zubkoff is a PhD MS Associate Professor in the Division of Preventive Medicine at the University of Alabama at Birmingham. She's Associate Director for Research at the Birmingham VA and at the Birmingham VA Atlanta GREC. And then last but not least, Dr. Daniel Matlock is Associate Professor and currently Interim Division Head of the Division of Geriatrics at the University of Colorado. He's also the Director of the Colorado Program for Patient-Centered Decisions. He's board certified in medicine, geriatrics, and palliative care, and his research really is focused at changing and improving how patients make decisions, especially around complex cardiovascular technologies. He's participated in a number of important initiatives that address shared decision-making, especially in the space of heart disease, and recently was also named Director of Implementation Research for the Denver VA Geriatric Research Education and Clinical Center. So as you can see, we are pretty lucky to have an incredible group of people engaging in implementation science and palliative care, and we'll turn it over to you all. Thank you so much.
Thank you. Thank you, Dr. Ritchie. That was a really great introduction. My name is Cara McDermott, and I'll be kicking off our discussion today around the Palliative Care Research Cooperative's Implementation Science SIG. Now, the goal of our SIG is to encourage collaboration and networking among researchers using implementation science to improve care for patients with serious illness. We're hoping that this group is a nice nexus of folks working in palliative care who are interested in implementation science and folks working in implementation science who are interested in palliative care. At this point, we're planning on quarterly meetings, plus a meetup at the PCRC annual investigators meeting. Next slide, please. At the end of this, we will get an email with a survey link, and we want to hear from you. Dr. Chek and I would like to know more about who you are, your research interests, your career stage, ideas for future meetings, and what would be most helpful for your research. That way, we can tailor future offerings to what SIG members are interested in. So please watch for the survey link immediately following this webinar. Next slide, please. So our goals for this session, we're going to start by reviewing some key concepts in implementation science. Then Dr. Check will be discussing hybrid implementation effectiveness study designs. And then we'll hear from Drs. Matlock and Dr. Zubkoff about palliative care studies that they're working on that use these hybrid designs. Next, please. So first off, I'm going to walk us through some key concepts in implementation science. Now, quick definitions. To note the difference between implementation and implementation science. And a lot of what we're going to talk from today draws upon the work of Jeff Curran. So for implementation, we have an active approach. We're working on behavior change and specifically to get research findings into routine practice, to work on uptake interventions. So that's implementation. Whereas implementation science is a rigorous study of the methods to promote systematic uptake of research findings. So we want to measure what's working. How are we going to get these research findings incorporated into routine practice? So this really focuses on how best to implement research and create generalizable knowledge so that others may learn. Next, please. So implementation science made too simple. So what we want to do is break down some of these key concepts and discuss things in terms of what is the thing, and that's the intervention or the practice or the innovation. So for example, the intervention might be a smoking cessation intervention that has a lot of great evidence behind it. So in clinical effectiveness research, we're looking at whether the thing works. So our endpoint might be days quit following intervention. But in implementation research, we're trying to figure out how to best help people in places do the thing. So we might have a fantastic intervention. However, if we don't have the resources or the time or the knowledge or the space to implement it, then it's not going to make it into routine practice. So what we're trying to do is figure out how to best help people or places do the thing. And so that might be to measure time allowed or to do a on-the-ground assessment of needs and feasibility and acceptability. So implementation strategies are the stuff that we do to help people and places do the thing. And so the outcomes that we're looking at then are how much and how well people do the thing. So for example, going back to smoking cessation, how much are folks in the clinic able to offer smoking cessation? Or how much are they able to offer a goals of care discussion? And then how well they do it would be, for example, how well they are able to deliver the intervention in terms of if the intervention has 5 components, can they deliver all of that? Do they have enough time to give the intervention so that patients can benefit from the full intervention? Next slide, please. So what do we do in implementation research? Well, first off is developing and testing a range of implementation strategies. So what works for which types of interventions or practices? You may find that an intervention works very differently in context X, which may be a rural community-based oncology clinic, versus context Y, which is a tertiary academic medical center. And context matters to the ability for people to deliver the intervention at all, and then how well they're able to implement it and deliver it. And then once we look at the different implementation strategies, we're trying to figure out how they work, why they work. So why does audit and feedback help adoption of prescribing guidelines? So why do some staff and some office arrangements lead to implementation, whereas others do not? Is it because of the presence or absence of local champions, and so on and so forth? Next slide, please. So one of the questions that you may hear is, are we still interested in the effectiveness of the thing? Does implementation science worry about the thing? And the answer is yes and no. So if the evidence base is very well established, for example, medications to control certain symptoms, we know that there is an armament of antiemetic therapy for patients receiving chemotherapy. So we're not going to necessarily test the effectiveness of Zofran or some of the other agents commonly used. We also know that specialist palliative care for people with advanced cancer has many positive outcomes. So we're not going to necessarily test the effectiveness of something with a strong evidence base. But if effectiveness data are limited, then yes, we would want to potentially test effectiveness and implementation strategies at the same time. Or we may need to adapt an intervention and want to know the implications of that. So, for example, with palliative care, if we're looking at primary palliative care in a rural oncology clinic that has never offered it, then we might be needing to also assess the evidence base there. Next slide, please. So now I'm going to turn over to Dr. Check, who's going to discuss some of these hybrid implementation effectiveness study designs that allow us to assess both implementation and effectiveness, depending on the situation.
Great. Thanks so much, Cara, and hello, everyone. Happy to take it over here with a hybrid implementation effectiveness design. So just to get us started here, I wanted to talk a little bit about the rationale behind this type of design. So the primary goal here with a hybrid implementation effectiveness study design is to hopefully speed translation. So the idea is that if we pursue effectiveness and implementation research questions in tandem, we can get effective interventions into practice faster than if we were to pursue these questions sequentially, meaning we'd first wait for the perfect evidence data, effectiveness data, and then start to write implementation grants. That takes a really long time, as folks know. So proponents of hybrid designs would say that even when the effectiveness data are not perfect, for example, we have a pretty good idea that the intervention works, but maybe it hasn't been evaluated in our specific population or context, we might still be able to start to pursue some implementation-focused work while producing more or better effectiveness data. So the idea of sort of backfilling the effectiveness data. Next slide, please. So there are three types of hybrid designs on the implementation, effectiveness to implementation, I should say, research continuum. And in the webinar today, we'll largely be focusing on type 2 and type 3 designs, which are more heavily weighted to implementation than our type 1s, but we'll talk a little bit about type 1s. If you'll advance the slide, please, Naomi. So in hybrid type 1 trials, we are evaluating the intervention and its effectiveness while gathering information relevant to implementation. So again, I'm not digging into type 1s today because they're primarily focused on effectiveness versus implementation. But usually these take the form of an effectiveness trial plus an implementation related process evaluation that is often qualitative or mixed methods, usually assessing things like barriers to and facilitators of implementation of the intervention in the context of that effectiveness trial. In a hybrid type 2, we're evaluating the effectiveness of the intervention, and we're also evaluating an implementation strategy or implementation strategies. And we'll talk a little bit more about this in a moment. And then in hybrid type 3, this is, we're evaluating implementation strategy or multiple implementation strategies and gathering information on intervention effectiveness. So a hybrid type 3 is primarily an implementation trial, usually comparing 2 or more implementation strategies, and then secondarily evaluating effectiveness outcomes. Next slide, please. Okay, so digging in a little bit on hybrid type 2s. So the goal here again is to evaluate an intervention and evaluate an implementation strategy or multiple implementation strategies. And this can take, a hybrid type 2 can take one of 2 common forms. So the first and more complicated and therefore less commonly seen is essentially an effectiveness trial within an implementation trial that is testing 2 or more implementation strategies. So in effect, you're testing the effectiveness of your intervention in the context of a trial, comparing the effectiveness of 2 or more implementation strategies. So this gets pretty complex from a design perspective, involves more than one level of randomization, and therefore is a little bit less commonly seen, although some folks certainly seem to pull it off well. The more common sort of subtype of a hybrid type 2 is an effectiveness trial, so an intervention effectiveness trial within a pilot, i.e. non-randomized study of a single implementation strategy. So all study sites are getting the same implementation strategy, and we're studying how it goes. We're looking at its feasibility and acceptability. Okay, so indications. Oops, sorry, one more on the last slide there. Indications are when we might want to think about a hybrid type 2. A hybrid type 2 might be appropriate if there are some effectiveness data for your intervention, but maybe not for your specific population or context of interest. Hybrid type 2 could also be something to consider if we have a sense of what the barriers to and facilitators of intervention implementation might be, so we can then design an implementation strategy or strategies based on those data on barriers and facilitators. Finally, something to think about is the extent of implementation momentum for your intervention. So sometimes the health system might really want to roll something out or might feel they need to roll something out, even in the absence of kind of ideal or perfect effectiveness data. And this might be a good time to think about testing both effectiveness and testing an implementation strategy. Okay, next slide. A few additional things to think about with a hybrid type 2. The implementation strategy or strategies should be explicitly described, and they should be plausible in the real world. So we could move them from the research context to the real world context. It's also important to distinguish what is part of the implementation strategy and what is part of the intervention. So where does the intervention end? Where does the implementation strategy begin? This is not always straightforward. It's something that I get tripped up on myself sometimes. So one example would be like with training, training clinicians to use the intervention. At what point does that start being sort of part of the intervention, an intervention startup, and start becoming sort of an implementation strategy? And I think people could disagree about that. It's just important to sort of decide how you want to distinguish the intervention and implementation strategy and justify that. And finally, typically hybrid type 2 trials include explicit measures of intervention adoption or uptake and fidelity, i.e. delivery as designed. Okay, and next slide, please. Okay, a little bit more about hybrid type 3s. So in a hybrid type 3, we are evaluating the effectiveness of implementation strategies and collecting intervention effectiveness outcomes. A hybrid type 3 usually takes the form of a trial comparing implementation strategies, typically 2 implementation strategies. They could be 2 different implementation strategies or perhaps a standard versus tailored version of an implementation strategy. Randomization is at the provider or clinic level, and intervention effectiveness outcomes are collected, but they're secondary. In terms of indications, some would say that you could potentially proceed with a hybrid type 3 without sort of completing the full portfolio of effectiveness studies. For example, if something is required in a health system and it's going to be rolled out anyway, a hybrid type 3 where you're really emphasizing implementation outcomes and slightly de-emphasizing effectiveness outcomes could be considered appropriate by some. I think it's probably better and easier to defend if effectiveness data on your intervention are pretty strong and pretty widely available. It then certainly makes sense to proceed to hybrid type 3, again, with a primary focus on implementation. Next slide. Okay, and at this stage, I'm going to hand it over to Dan Matlock, who will share his experience with hybrid type 2 design. So really looking forward to hearing from Dan and then from Lisa. Thanks.
Thanks, Devon. Yeah, I'm Dan Matlock from the University of Colorado, and I'm going to talk about a trial that I ran with a heart failure colleague here, Larry Allen, and Colleen McElvennon, who's a PhD nurse practitioner in the heart failure service. The three of us have been working in the LVAD decision-making space for almost 10 years, I guess. And this is one of our big trials we ran between 2014 and 2017. Next slide. So this is a picture of the front page of this decision aid we made. In the interest of times, I was supposed to talk for 7 to 9 minutes here. So I kind of assumed a palliative care audience would have some basic understanding of an LVAD, at a minimum that it's a big decision with big trade-offs. And then I didn't get into the literature on shared decision-making either, because I sort of believe palliative care is a form of gold standard shared decision-making. But this is a trial of a decision aid we made. We interviewed patients and docs and caregivers. And from those interviews, we learned they would love to hear from other people. And that led us to make this decision tool in a 26-minute video. And I think implementation begins at the time of design. You want to include multiple stakeholders in your interventions. I think there's lots of decision aids out there with lots of tightly controlled efficacy trials, and they're all sitting on shelves somewhere and nobody's using them. And I think it's often a design problem because they weren't designed to fit into the clinical context in some way. So we took an approach early on of including as many stakeholders in the development as possible, and caregivers and patients, and came up with this intervention. And there's actually a great paper called Designing for Dissemination. Ross Brownson is the lead author. But basically, they talk about the importance of multiple stakeholder engagement at the time of intervention design. So anyway, we had this intervention. We wanted to test it. But next slide. So we proposed this Decide LVAD trial. And our primary objective was to understand the effectiveness and the implementation of a shared decision support intervention. We had not studied the effectiveness of this yet. We'd had a very small pilot trial of basically feasibility with 10 patients. But we didn't want to study a tightly controlled efficacy trial and have another decision aid that wasn't going to be used. So we proposed this implementation design. Next slide. And with decision tools and decision aids, I don't think you should have a decision aid for every decision, but I think they fit really nicely for some of these big high stakes decisions to let people have time to soak in information. But then you have this problem of how hard it is to actually implement them, because you have questions like who's going to deliver it? Will it be a provider or staff member? How will you deliver it? Is it going to be through the electronic medical record or in person or mail? Next slide. And different decisions require different decision aids. We have a 26-minute video for an LVAD in my primary care clinic. I don't think there are many decisions I talk about that anybody would spend 26 minutes watching a video for. And yet here we heard from people they wished it was longer with more vignettes in it. And then the last question, this is one of the hardest, is when will it be delivered? You want to get a tool like this in somebody's hand when they're thinking about a major decision. If it's too late at the time that they've signed their consent and they're getting wheeled off to their procedure, it's not going to help them decide. And if it's too early, it won't be relevant. I can type that reference in later. Ross Brownson is the lead author. It's called Designing for Dissemination. Next slide. I was just pushing page down, wondering why it wasn't advancing. So this led to this systematic review about implementation of decision aids. This is getting a little old now, but it's still, I think, pretty relevant. This just basically concluded after reviewing implementation that there's not much successful implementation of tools like this. Next slide. So we proposed the Decide LVAD trial, which was this multi-center trial of this intervention. It had 6 sites, and this was proposed as a step wedge design. And we called it a type 2 hybrid design. And hearing Devon's description of type 2 hybrids, I think someone could argue that maybe this is a type 1. But you know, that's probably worth debating. Next slide. So some of our key considerations in designing this and picking this stepwise design is we wanted to implement in real world settings. We did not want to do another decision aid trial where a research assistant sits down with a patient and makes sure they see the decision aid. And then lo and behold, the patient has a better understanding. That's not real world, but that's why decision aids have all this data that they work. So we kind of made it a rule that study staff could not deliver the decision aid. We had to convince the sites to do it somehow. We had to, you know, these sites don't use a lot of, don't do a lot of LVADs. So, you know, at the most, we could probably count on a site to get us 25 to 50 patients per year. And that's if we get a large percentage of their patients. And with the budget, this was a 3-year PCORI grant. We could really only afford about 5 to 6 sites. Randomization, we wanted some kind of randomization because we wanted to test effectiveness. And then with decision tools, this is a dyad. The intervention isn't just for the patients, it's the clinicians and the patients. And we constantly say in our group that we want, with decision tools, you're not just designing for the patient, you're designing for both. And that creates difficult design decisions at the beginning, but those difficult design decisions in the beginning have helped us later. Next slide. So we considered a bunch of study designs. A classic patient level randomization we didn't choose because the intervention is both the patient and the program based, and that we're trying to convince the program to use it. So it's not an individual level thing. We were pretty confident that a decision aid trial would improve decision-making outcomes with a classic patient level design. And then we were worried that diffusion among participants at each site was probable. As the docs saw patients using it, they would change their discussions with control patients. So then we considered a cluster design, but like I said, we could only really afford 6 sites. So we'd have 3 sites with interventions and 3 sites with control, which gets statistically challenging and a little bit dubious. So we proposed a step wedge cluster design. Next slide. Next slide. There we go. I must have doubled up a slide there. Sorry about that. So this is how we rolled out the step wedge design. We had 4 steps. We had 4 smaller sites and 2 larger sites. We were the coordinating site. So this kind of violates a traditional step wedge design because you're supposed to randomize all the sites. But we had our site go first because we'd already been piloting here, and there were people on the service that were already wanting to use it. And we wanted to work out some of the details at our site before we went to the other sites. And this was a figure I took out of the grant. We ended up not doing a 4-month rollout period. We only had about 2 weeks where we didn't collect data while we were getting the intervention rolled out. And then any patient enrolled after that was considered an intervention patient. But the way a step wedge design works is you randomize the rollout so that at the site level, it's basically a pre-post design. But then by randomizing the rollout, you can at least make some conclusions about secular trends. I'll tell you right now, in another trial I'm running just like this, the ICD trial, there was one major secular trend with this little virus that's really messed up that design. And then Medicare mandated shared decision-making for defibrillators at the beginning of the trial. So my control group was completely contaminated. So this idea that rolling out a step wedge design this way helps control for secular trends, I don't think is true. I think secular trends still happen, but it's at least better than just doing a straight pre-post. Next slide. And then, so we chose this design. We thought it was ideal because we were worried about diffusion of the intervention to control participants in a patient level. We wanted to learn about implementation. The staggered rollout just logistically helped us a lot. We weren't trying to implement at 6 sites all at once, or even if we did 3 and 3, we weren't trying to implement at 3 sites all at once. We could kind of work on one site, then work on the next, then work on the next. So from a work and study perspective, it kind of fits nicely into a Gantt chart. And then this was an intervention. It's a tool, it's a video. All the sites had seen it, many had helped us make it, and they all wanted to use it. So being randomized to a control group actually isn't very good politics for getting sites to stay involved. So next slide. So our implementation strategy or intervention, we designed a strategy that was very low touch. We did go out to the site for this first trial. I'm not even sure that was fully necessary, but we did. And Larry gave a big grand rounds presentation. And then Colleen gave a communication training. And then we sat with the team and discussed a new process. And I'll tell you, the LVAD space, as an aside, was the easiest context to implement a decision aid, because they already have a team of these mechanical circulatory support coordinators that are already educating patients, and they're already using tools from industry. And they told us in the qualitative work that they don't like those tools because they know they're biased. So it's a pretty easy sell to an MCS coordinator to kind of unplug some of those other interventions and plug this one in. And then post-implementation, we offered ongoing site support and follow-up visits. And then we studied that. Next slide. So for our evaluation, we used REAIM. I'm here at Colorado. Russ Glasgow is the head of our implementation program. So we're very REAIM heavy, but it's a really easy implementation framework to understand. Lately, I've been using PRISM a lot more, which is basically REAIM plus textual factors. There are lots of good frameworks, and it's hard to say which one and choose which one you need to choose. This one I like because it's really easy to write about as well in grants, and it really helps you organize your thinking. But we measured REACH, which was the % of eligible patients. We did measure effectiveness to see if it improved knowledge or value treatment concordance. We then looked at adoption. Did sites use this, and who at the sites used this? And much of our adoption assessment was done qualitatively. It was a little artificial at the beginning because all the 6 sites we approached all said yes. So at that level, we had 100% adoption, but we were also asking friends and people who we knew would be involved. So we kind of asked early adopters. And then we studied implementation both quantitatively with somebody at their site filling out a checklist for how they used the decision tool, and who was with them. Was the caregiver with them? Do they require a caregiver with them? We had a bunch of questions that the coordinator or the study person we called it the fly on the wall survey, where the study coordinator is not allowed to deliver the intervention, but is just kind of there watching and figuring out how it does. And then we also did a lot of interviews. So we studied this qualitatively as well. And then maintenance, we've looked at, did sites continue to use it after the trial? Why or why not? And I can stop there. I think that go to the next slide. Yeah, so then I included 4 or 5 slides with some of the results. I may be one of the coordinators. Should I run through these real quick, or should we move on to the other design? I wasn't sure what our timing would be.
I think, Dan, how much longer do you think you might have?
Like 2 minutes, 3 minutes?
Yeah, I think go for it.
Okay.
Yeah.
So we enrolled 248 patients from 6 sites. And you can see somewhere in the control, somewhere in the intervention. We did have a secular trend that you can sort of notice here. If you look down at the Intermax score, the intervention groups, they tend to have lower Intermax scores, which means they're healthier patients. So one of the things we saw through the trial is we think that the sites started using the decision aid for people who weren't as sick. So the later sites who were all the intervention, we enrolled patients who weren't that Intermax 1, 2, or 3, but who were actually later in their Intermax scoring. This is just a score of severity among transplant patients. Next slide. So for the delivery, we trained all the sites participated. We had approximately 31 to 72 people per site for the training. This next bullet is basically the reach. 88% of people got the written decision aid and 92% got the video decision aid in the intervention arm, which is really high reach for an implementation trial. And then the education materials were actually felt to be biased in favor of the LVAD. And we saw this in more common in the control patients than the intervention patients, but not significantly. And we like to present this number because so many of the docs are concerned that the materials are biased against the LVAD. So most people felt it was either neutral or slightly biased towards the LVAD. Next slide. Our primary outcome from efficacy was this decision quality, which is a parallel construct of knowledge and value concordance. And we saw about a 5% increase in knowledge, which was significant, but not that exciting. And next slide. And we saw a huge increase in value treatment concordance, which is, I took out the slides on how we measured this, but we just sort of had one scale. Do you want something major to live longer? Or would you rather live with what time you have left and avoid major interventions? We worded it better than that, but basically we had people put an X on a line. And then was their treatment concordant with what they said they'd rather do? And we saw a big increase in that. Next slide. And secondarily, in our intervention arm, there was a pretty big reduction in patients who chose to get the LVAD. And again, some of this could be because some of those patients weren't as sick, that secular trend I was worried about. And some of this could be our intervention. I will say we have a follow-up grant from PCORI where we're trying to disseminate this tool nationally. And this finding here for about 20% of the sites is the biggest barrier to implementation because keeping their volumes up for some programs is a very important thing. And the fact that our prior trial lowered the people choosing it is concerning, despite the fact that they were more knowledgeable and the decision was more value concordant. Apparently that doesn't matter to some sites, but we're working on them. Next slide. Yeah, and I think that's it. That's all I've got.
Thanks, Dan. I think now we'll turn it over to Dr. Zubkoff.
Okay, thank you very much. My name is Lisa Zubkoff, and I'm here to talk to you about an NCI-funded R01 that's titled Implementing Palliative Care, a cluster RCT comparing a virtual learning collaborative and technical assistance strategies. Next slide. So a little background information. The ASCO recommends early palliative care for patients with metastatic cancer and/or high symptom burden. The ENABLE program, which stands for Educate, Nurture, Advise Before Life Ends, is a nurse-led, evidence-based early palliative care intervention. And the ENABLE program for patients consists of a palliative care assessment, a phone-based curriculum, and monthly phone follow-up. Prior research demonstrates the effectiveness of the ENABLE intervention. There's been a couple of studies to test the effectiveness. The first study, there was a comparison of ENABLE versus usual care. And in this study, they found that patients that received the ENABLE program had improved patient quality of life and improved mood. There was a second study that compared early versus delayed intervention, meaning that folks that got the ENABLE program at the time of a newly diagnosed advanced cancer, delayed intervention was 12 weeks later. And this study found an increase in survival, but no difference in patient-reported outcomes. The takeaway from these studies is that the ENABLE program has been found to be effective. Next slide. So the goal of the study that I'm talking about really is building on prior research. And what we're hoping to find in this study is what is the best method to implement the ENABLE early palliative care program in community oncology practices. And in order to do so, we are studying two implementation strategies. One is the virtual learning collaborative. This was developed by the Institute for Healthcare Improvement, or IHI. And this is a quality improvement approach to guide clinical teams in implementing evidence-based practices. It brings together clinical teams via a web-based facilitated group interaction. So in other words, it brings together multiple practices to learn, together as they implement something. So there's often on these calls, there's not only an education piece, but there's also group facilitated conversation or discussion. And there's also teaching about quality improvement and how that can help with implementation. The second strategy is technical assistance. This is probably something that you all have heard about. It's an interactive support that is individualized to the specific needs of individuals or teams. This is done monthly as part of this project, and it's done on a one-to-one basis where teams, a team or a practice, have a web-based expert consultation with each practice. So there is no group phenomenon as part of this. It's really a practice has a consult with an enable expert that can help them as they are implementing the enable program. There's no teaching, there's no formal education, and there's obviously no group dynamic or quality improvement learning as part of this strategy. Next slide. So a little more background information on the study. Picking up on the earlier conversation, this study is a hybrid type 3 cluster randomized controlled trial. Two of the most important reasons why we chose this design is that there have been prior studies to test the clinical intervention, which is the enable program. Also, that we're most interested in how to support sites in the real world implementation of the program. This study is also guided by the RE-AIM framework, and we also used Proctor's implementation outcomes framework to help us to organize our outcomes. It's a complicated study, and so we found it really helpful because this groups outcomes into implementation outcomes, service outcomes, and client outcomes, which we found really helpful for us because these types of studies have so many outcomes that it can be almost overwhelming. And so we use that as well. Next slide. So here's a picture of our study design. And as I mentioned, it's a hybrid type 3 effectiveness implementation cluster randomized controlled trial. We're conducting this study in 48 community oncology practices that are affiliated with the National Cancer Institute Community Oncology Research Program, which is otherwise known as NCORE. Participating practices are randomized to participate in either a 15-month virtual learning collaborative or 15 months of technical assistance. Practices will implement the enable program and offer it to eligible patients with advanced cancer and their caregivers. For feasibility of carrying out the study activities, we're recruiting sites to participate in 3 cohorts. And this is really just because it's such a large trial that we needed to break it up. Next slide. So now I'm going to introduce the aims of the study and hoping that this will help clarify things a little bit. So our primary aim is a patient level aim where we're going to compare the effectiveness of the virtual learning collaborative strategy versus technical assistance strategy on enable program uptake. We're defining that as the proportion of patients who complete the enable program. And that means that patients get the palliative care assessment and 6 nurse coach phone sessions. Aim 2 is a practice level aim where we will compare the effectiveness of the virtual learning collaborative versus technical assistance on NCORE practices overall enable program implementation. We're measuring that with the general organizational index. This tool assesses implementation, including factors that influence institutional implementation. This instrument is scored quantitatively based on structured interviews at baseline, month 6, and year 1. For this aim, I will say that we also are measuring a whole host of other implementation outcomes, including things like the re-aim. We're doing a survey on provider perceptions of early palliative care, and then we have several fidelity outcomes as well. Next slide. Exploratory aim 1 are our patient and caregiver outcomes. So we will compare NCORE practices randomized to the virtual learning collaborative or technical assistance on patient and caregiver quality of life and mood outcomes. And we have the main outcomes for both patients and caregivers listed on the left, but I will say that there are many other measures and outcomes that we are collecting. And then our exploratory aim 2 is really just determining the relationship between enable program uptake, which is our aim 1, the overall enable program implementation, which is aim 2, and then patients' quality of life and mood across the 2 strategies, which is our exploratory aim. Next slide. So here are our participant inclusion criteria. For patients is listed on the left-hand side of the slide. Although not required, each patient can identify one caregiver to participate in the study and also receive a portion of the Enable program. Caregivers are identified as someone who is an unpaid relative or friend who knows the patient well and provides support to their cancer care. And the inclusion criteria for caregivers is listed on the left. Next slide. So here's a little status, here's the little status on cohort 1. We are still in delivering cohort 1. The study is ongoing. So we have recruited 9 practice clusters for cohort 1. And in that cohort, there are 22 nurse coaches who are interventionists, 38 physicians, and 17 coordinators. We have I think it's about 10 patients and 5 or 6 caregivers that are enrolled at this time. As part of the study, we are offering many trainings. And one of the most important is that we offer a web-based training for nurse coaches to teach them how to deliver the Enable intervention or program to patients and caregivers. This includes reviewing the Charting Your Course manual. There's one version for patients and a second for caregivers. We also provide scripts to nurse coaches for when they deliver or to help guide delivery of the sessions, both to patients and caregivers. Where we're at right now is that we've completed all of the baseline measures, both for practices and personnel, and then obviously for the patients that have gotten that far in the program. The virtual learning collaborative and technical assistance are ongoing. And as part of that, we do track participation and engagement, as well as fidelity, not only to the Enable program, but also to the virtual learning collaborative and the technical assistance implementation strategies. And then, as I mentioned, the practices are enrolling patients and caregivers and are delivering the Enable program to those participants. Next slide. So although the study is still ongoing, we already have some lessons learned. I think one of the first lessons is that there's real value to conducting research in a consortium. By doing so, we have access to a large number of community oncology practices that had we not done so, we would probably spend most of our time just trying to recruit sites to participate in a very large implementation trial, and that we could really struggle, particularly in a time like now during during COVID, when sites are completely overwhelmed and are just focusing on delivering care. At the same time, we are rolling this out in cohorts because it's a lot of work, but it's really hard to get sites all on the same timeline. And so we have had some challenges around recruiting sites in cohorts and getting everybody ready to go at the same time. There's also been some challenges and efficiencies of training nurse coaches in palliative care via web-based training. I think most importantly, we had originally thought that we would train people in person, that we would bring folks somewhere for 2 days and we would teach everybody at the same time. One of the problems in doing that is that there's always staffing turnover, or there may be new hires, and that when you want to expand the program, the sites don't have the capacity to do so. So we decided that we would go virtual and we would do our training virtual. Well, the problem with that is that when you don't remove people from their day-to-day responsibilities and ask people to do virtual training, it can often be very hard to find the same number of hours in which to complete the training when they're still being asked to do their day-to-day job. And so the number of hours didn't really change, but we're finding that the interventionists or nurse coaches are telling us it's really hard to get the training done. That said, the training is no small task. It's about 19 hours to complete the training. And so we are sensitive that it is a lot of training. At the same time, once that's done, they are able to deliver an early palliative care intervention, not only to study participants, but also they may be able to offer a service that they were not otherwise able to provide to their patients. So in summary, I think my takeaway thus far is that multi-level research to study the implementation of evidence-based practices is really complex. There's a lot to measure, there's a lot to track, but we're learning a lot, and we're really optimistic that this trial will be really important and hopefully will provide a lot of insight into future work that we hope to accomplish. So I'll stop there, and I thank you very much for your time.
Thank you so much, Dr. Zubkoff, and to the rest of our panel for a great discussion. We still have just a few minutes, about 7 to 8 minutes for questions and answers. And while you're typing in those questions, I'd like to remind you that this is the Implementation Science SIG launch. In the evaluation that you'll see after this webinar, I will provide for you the survey link that Drs. Check and McDermott referenced to, as well with instructions on how to sign up for the Implementation Science SIG. So we hope to see your membership through there. And just to remind you, you must be a PCRC member to apply for the SIG. And up next in October, we have another SIG kickoff with our liver disease special interest group. And so Drs. Arpan Patel and Ann Walling will talk about helping patients with advanced liver disease and caregivers live better. And for that, I just want to leave a little bit of time to go over any questions that anyone might have remaining.
And Naomi, we do have some questions that are coming in. So we have a question about how do you recommend working with clinics and sites to engage with implementation studies? How can we as researchers make it less burdensome for them and mutually beneficial?
Yeah,
But
oh. I'd be willing to say a little bit about what I did since it was a very large trial. I approached, and again, I was working with a consortium, but I approached the teams or, the consortium that I was interested in the planning phase. So again, it was really part of the grant process, the grant writing process, to work with them and to solicit their input as part of the process. And this was 2 years before funding. In fact, I would go and present to the sites and solicit their feedback and would take their advice on changes. So I had a few ideas that I thought were quite brilliant. Turns out I was very wrong. And I took their advice when they said, great idea, we'll never do it. And so I really engaged them very, very early in the process and would go to them and say, hey, what do you think of this idea? So I would encourage you. I had the luxury of having that infrastructure, but even if not, approaching folks early in your process would be my number one advice.
Thanks, Dr. Zubkoff. And I feel like Dr. Matlock, you said something similar when you were talking about your project and how important it was to really connect with people early on. The next question is basically about where did it go? Here, are there best practices to be able to continue tracking the implementation outcomes such as adoption after grants are over? It seems like unless there's continuous grant funding, this is difficult, or at least support through clinics, university funding. So how do you all navigate that challenge of the funding is over, but you still feel like you need to sort of understand adoption or other relevant implementation outcomes?
yeah, I don't know. I mean, somebody's got to get paid. And so that takes somebody's time to do it. And so you need some funding somewhere if you want to continue to track things like adoption or sustainability at sites that have already adopted, those things that you try to do after the grant's over. If you have an online intervention or something, you might have easy ways to track it there, but there's no easy ways to track if people are using your thing. I think I'd be open if somebody has another idea, but I can't think of
Yeah, it's challenging. We tried in our most recent proposal that used a step wedge design, like the design that Dan was describing, to try to build in like a sustainment period after each kind of wedge, I guess, of at least like a few months or 6 months. You could look at sustainment kind of as the intervention rolled out, but that's the only method that I have experience with, like within the limitations of grant timelines and things. But it's a great question and one people are still grappling with.
And one to plan for maybe going forward as you're thinking about your funding and how you actually want to have your grant funded on the front end. And then the last question before we conclude is, could you speak to some different kinds of sort of tactics for engaging in implementation research, including mixed methods designs, which of course in some respects you've touched on, but if you have any sort of additional words of wisdom around implementation delivery strategies through mixed methods, I think that would be of interest to this questioner.
Yeah, I mean, we were talking mostly about trials today, but even in the context of trials, there's a huge role for qualitative and mixed methods. A hybrid type 1, which we didn't really talk about today, is essentially the trial plus usually a mixed methods or qualitative. Some mixed methods or qualitative work to get at how's implementation going, what's making it challenging, what would make it easier, that type of thing. We could do a whole other session, and maybe we will if it ends up being of interest, on kind of study design and implementation, because it's not all experimental research, right? There are other sort of pre-implementation studies where qualitative and mixed methods plays a big role too. So we can chat more about that if that's of interest.
And there are some other cool, I think that's a good comment. And there are some other cool designs like smart trials and adaptive trials that people in implementation sometimes do, smart trials are just, I think, a subset of adaptive trials where you sort of pre-specify some of the decisions you might make down the road. I've never done one of those, and they're complicated, and to really get power at those later decisions, you have to have a really large sample size, or those later decisions are kind of exploratory, but they're really, really clever designs that overcome some of the challenges of even the step wedge design to allow you to learn as much as possible.
Wonderful. Well, thank you for an incredibly instructive presentation. I think we all learned a lot. And as one of the participants put in the chat, it's always useful to see real world examples of what implementation science looks like in real life. Please fill out the Survey Monkey that is just popping up on your chat feature now so that you can help the implementation science special interest group get launched forward with a lot of energy and momentum. So thanks everybody, and have a great rest of the day.